Today we're going to be going over EKGs. We're going to start with the process of approaching an EKG from top to bottom. Whether you're a student or a provider, these are kind of the steps that you need to have in mind in order to see everything on an EKG. You'll only see what you're looking for, so make sure that you're looking for the right things. So starting with reading an EKG, this is the process. So you're going to start with an initial scan, then determine rate and rhythm. From there, you look at access, and then we're going to break it down into the different waves and segments and intervals to determine the length and morphology to really tell if there's something abnormal with the atria, the ventricles, and with either their depolarization or repolarization. And then at the very end, we can return to some of those isolated abnormal beats or pauses. So starting at the beginning, you're going to look through an initial scan. You're going to say, is this EKG relatively consistent across the whole thing? The reason is because if you find things like grouped beating, pauses, or abnormal beats, you're going to want to reserve those for the end until you have determined all of the other steps of the EKG so that you can make sure you look through every single portion. First, we're going to start with the rhythm. We're going to say, is this regular or irregular? And the way that we answer that is by looking at the P wave. So I want you to look and see if there's a P wave before every QRS complex. Usually I start by looking all across lead 2 or whatever your bottom strip lead is, and that will kind of tell you with relative confidence if there's P waves before every QRS in the other leads. Now, if there are P waves before every QRS, that's considered regular. If there aren't, it's irregular. Now, if you say that something is considered regular, then you also need to make sure that there's still a one-to-one conduction, because what may happen is that you have a P wave before every QRS, but then you have all these extra P waves lying around. So if there's only one P wave to every QRS, then it's considered regular. If there isn't, then it may be a block or even something like a flutter. However, if it's an irregular beat, you can tell that there are P waves without QRS complexes, which is kind of that block, AFib, A flutter that we just talked about. It may be only present in a small portion or segment, so you need to make sure that that's consistent throughout the whole thing. And you want to watch and see if there's any correlation with activity. So maybe they were exercising and that changed the beat, or that they have something like in a sinus arrhythmia where they inhale and the beat changes with their respirations. And then the last thing that you're going to do is say, no, I don't see any of these P waves before QRS, is you can look at after the QRSs and find something like a retrograde P wave, and we'll look at a few of those in a minute. So starting here, these first two EKGs are literally just terrible quality, but what I want you to look at is V1. Now, if you don't see a P wave before every QRS, or if these beats look irregular and abnormal, you can always confirm atrial fibrillation by looking at lead V1. I don't know why, but it's always the most consistent. Here's another one looking at V1, but as you look, there's not a distinct P wave before every single one of those QRS complexes. Here's kind of a more crazy one, but you can tell that there's no P wave before every QRS, and that leads you to realize that there's also not a consistent beat. These are spread way far apart, way close together, and you can tell that this is an irregular beat. Once again, that's AFib. It just has some aberrant conduction, some ST elevations, and you can confirm that in V1 because there's really just this, it almost looks like static. Here's one of your favorite diagnoses ever. You're going to love it. Because it's always so distinct. That's a flutter, but what I want to show you is, hey, it looks like there's a P wave before every QRS, but there's multiple P waves, and so that you can tell that it's not a regular rhythm. So this is something considered a flutter. These are actually called F waves. They're not even considered P waves, but that's why it's important for you to look if there's a P wave before every QRS. Same thing here. Now look, oh, there's a P wave. Where's the P wave there? Where's the P wave there? Where's the P wave? You can also tell that there are P waves without QRS complexes, such as right here. You can tell that they're kind of regularly spaced, but they're not triggering QRS complexes. So the question that you can answer here is not just the diagnosis, which is third degree AAV block, but you can also determine, hey, the atria and the ventricles are not communicating. The atria may be firing and eliciting these P waves, but it's never getting down to the ventricles, so the communication is off. And that's really what we're trying to figure out. From here, this is an example of retrograde P waves, and there's multiple different types. What this tells us is that the atria may be firing, but the ventricles are kind of getting the jump on them. And so we can see that there's a retrograde P wave that's inverted, one that's maybe buried within the QRS, or it can be behind the QRS. So you're going to see this diagram quite a bit throughout the rest of the presentation, and the reason is because I kind of wanted a synthesis of a single slide that you could always come back to. So by the end, this will all be labeled. The P wave is really what's going to help us determine our rhythm. Is the rhythm normal? Is there a P wave before every QRS? Next, we're going to look at the rate. We're going to do the first initial way to do it is by memorizing really this R-to-R interval measurement pattern, and it's 300, 150, 100, 75, 60, 50. You can look at every set of big boxes between the QRS complexes and find out the rate. So for example, let's go back to one of our QRS complexes and the A flutter 12 lead EKG. So we're going to start by finding a large box, finding a QRS that really falls relatively close to the large box. Then we start by counting the first one here, 300, 150, 100, 75, 60, and it's somewhere between there, so I can say it's about 70 beats per minute. Now the other method is what you're going to use for either irregular beats or less than 50 beats per minute. And it's the 6x10 rule is what I call it. So either you can find 2 3-second marks and times it by 10, or you can see that the bottom strip on most EKG papers is going to be 10 seconds long, so you can multiply it by 6. So for example, let's go back to our AFib that's very irregular and even a little bit slow. So you start by saying, okay, this is 10 seconds long if I use the whole strip. Then you count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 beats in 10 seconds. So we times that by 6 and we get about a rate of 60 beats per minute. From there, we want to classify the rate. So here you have the rate classification. You have the beats per minute, and you have where in the heart that's actually firing from. So if you're seeing a rate of anywhere from 60 to 100 beats per minute, that's usually coming from the SA node. That's normal. If it's higher than that, it could still be coming from the SA node, just rapid firing, or it could be multiple foci from either the atria or ventricles that are firing all at different times, causing this rapid heartbeat. The next thing that you could notice is a bradycardic heartbeat, and that can come from the SA node firing slowly, or it can be located within the atria itself, not from the SA node. And that's going to fire a little bit more slowly. Same thing with severe bradycardia. You're looking at something below the atria, which is why we say that the SA node is the primary pacemaker, because it's what's going to beat at a rate that's appropriate for our needs in the body, for perfusion. So although the AV junction and the ventricles can take over, they're beating at a much, much slower rate and putting the body at much more risk. So for example, we're going to do another one here where we look at the rate being at 300 right here, 150, 100. So the rate here is 100 tachycardic, and it's likely coming from the SA node. Here's my next example. So we're going to start by looking for a QRS complex that falls relatively close to the large box line. So at 300, 150, 100, 75, 60, 50, 40. Oh, we're getting down there pretty slow. So I'm going to switch over now that I know it's less than 50 beats per minute to my regular formula, my 6x10. We're going to say, okay, so there is a 10-second strip down here, and we are going to count 1, 2, 3, 4, 5, 6, 7. 7 times 6, we're getting a rate of about 35 beats per minute. That's going to be considered bradycardia, and in fact, severe bradycardia, and likely it's coming from an origin that's below the atria. So here's our summary slide. Once again, we're seeing the rhythm is going to be determined by the P wave, but the rate is the R to R interval. Now moving on to axis, you're going to use leads 1 and AVF to determine the axis. So I like to use the thumb method, where I place my thumb up or down based on the deflection of the QRS complex. So if it's upright in both, you're looking at more of a normal axis. If it's upright in one and down in AVF, then the hand with the thumbs up is going to be the side that it's deviated to. We'll go over this on the next slide, but for example, in that case, my left hand is thumbs up. You can see here. So it's a left axis deviation. Same thing for right, but it's opposite. Now, there may be some circumstances in your book or in your class where they tell you, oh, if one's isoelectric, then you have to do these calculations to determine whether it's a right or left axis deviation. To be honest, if it's neither up or down, it's kind of right in the middle, I would just guess, or that's terrible advice, I know. You can learn the calculation method. However, if it's not severe enough to show you on the EKG that it's for sure right axis or left axis deviation, then it's likely not going to give you any good information at all anyways. Clinically, it's really not going to help you. So I would prefer to just look at those kind of obvious cases of left and right axis deviation. So we're going to look at this one. For example, in one, it's upright. So we have a thumbs up. In AVF, it's down. And so obviously that's your left hand, and that gives you left axis deviation. Over here, we're down in one and up in AVF. That's your right hand. That's going to be right axis deviation. Now moving on to the P waves, this is where we are kind of transitioning into the waves and segments portion of reading an EKG. So first you're going to go to the P wave, right? Because that's where it should originate. That's where the atria fires and determines the conduction throughout the rest of the EKG. So see first if all the P waves are the same. You can ignore leads AVR and V1 if you want to, because they're going to have different orientations and morphologies, but look at the rest of the strips. Are the P waves somewhat the same? So if the morphology is that normal single hump, then you're good. You can even check before that hump if there's a spike that indicates that there's probably a pacemaker allowing the depolarization of that atria, but it's still a normal morphology. Now, there's multiple types of abnormal morphologies and causes, but these are just some examples. So if it's flat or absent, you may have, a rest, a pause, AFib, which has no P waves, a flutter, VFib, VT, and we're really seeing some of these abnormal, absent, flat morphologies. If it's just squiggly, not even real distinct P wave, you're looking at something like AFib. If it's biphasic or a double bump, you're looking at SVT or atrial enlargement. And if it has kind of different morphologies all throughout, you're looking more something like wandering pacemaker or multifocal atrial tachycardia. Then you look at, it may be a normal single hump, but is it upwards or downwards? It should be upright, and it's abnormal if it's downwards. Then you can determine the width of that actual P wave. It should be less than 120 milliseconds. That means the atria is functioning normal. If it's wider than that, we're usually looking at something like atrial enlargement, because it takes a lot longer for the atria to deliver that entire P wave because it's still depolarizing, which kind of gives you a good indication on EKG of the size of that atria. Then you can check the height. It should be about 2.5 boxes high. If it's any taller than that, once again, we're looking at that atrial enlargement. So for example, I want you to look at these. These are normal morphologies, or so we think. If you look, there's some that are just double bumped, or these really tall bumps. You're actually looking at something like SVT here. The normal morphology just really isn't there. Here's another example of kind of some of those double bumps or abnormal morphology in the P wave. Another example of SVT. But really, some of the big things that you're looking at, is there any atrial enlargement? So for left atrial enlargement, you're looking for this wide bump, and that's called P mitrale. The reason is there's a lot of things that can cause left atrial enlargement, but it's only really isolated left atria if it's mitral stenosis. Otherwise, you can have anything in the ventricles that's kind of trickling backwards, any of those valvular abnormalities that can also cause that atrial enlargement. For right atrial enlargement, we're looking at anything that causes high pressure in the lungs that causes that hypertrophy of the right atria and ventricle. So you're looking at more of this taller type of P wave. When they're put together, they're tall and they're wide. Now you can look at V1 and lead 2, but V1 already has some weird diphasic morphology of the P wave, so I just completely ignore that. Look at my lead 2, and that can help me determine the cause. So if you look here at these P waves, we have good P waves. They're present before every QRX, but they're very wide and these large humps. That's going to be P mitrale. And you can see these, look at how tall those are in relation to the QRS. That is completely abnormal. That's P pulmonale, that really large atrial enlargement. So we know that the rhythm is the P wave, the rate is the R to R interval. The P wave duration should be less than 120 milliseconds and less than 2.5 boxes tall. Then what I like to do is look at the P to P interval, and this is not really on that chart that I've been showing you, but what you can do is march out the P waves and ignore the QRS complexes. If you see regular intervals of P waves, regardless of the QRS complex, that means that the atria is firing normally. The reason is because later you may be looking for something like AV dissociation, and if you can tell that the atria are firing on their own and the ventricles are firing on their own, but they're not communicating, there's quite a few diseases that can be present. Here's a little small list that I made from memory here. So for example, in this case, you can see, oh, there's a P wave, there's a P wave, there's a P wave. They're all relatively normal in their length apart from one another. However, P wave. However, they're not communicating well with these ventricles. The ventricles may even have somewhat of a normal marching out, but this is considered AV dissociation. The same thing is occurring here. You have P wave, P wave, P wave, P wave, P wave, P wave. So they're kind of marching out in more of this normal pattern. However, they're not communicating with the ventricles. This is considered complete heart block. So I just put it on here for just a second. I'll take it off, but you can march out those P to P intervals to see if there's any AV dissociation. Then we're looking at the PR interval, and this is kind of a misnomer because we actually start at the beginning of the P wave and go, as you can see, to the QRS complex right at the very beginning. That's considered our PR interval, so we're not going all the way to the R wave. But what's important about this is determining if it's shorter or longer. Now, about 120 milliseconds to 200 milliseconds is normal, and the reason is because, of course, it needs to be at least 120 milliseconds because that P wave is included. And if it's any shorter than that, then we're looking at some more of these shortened PR segments, such as pre-excitation syndromes like WPW or LGL, where the P wave may be present before the QRS complex, but the ventricle is actually excited before the P wave fully delivers its message down through the AV junction. Now, if it's longer, then you're looking at things like blocks. This is definitely a prolonged PR interval is a hallmark of first and second degree AV blocks. Third degree AV block technically has a long PR interval, but it's actually considered AV dissociation instead. Hypokalemia can cause it, as well as any medications that block the AV node. And the reason is because, once again, the communication from the atria down to the ventricles is purposely blocked. That's why we're trying to use these medications to stop the signal from getting through so we can slow the heart rate down. If the P wave is absent or retrograde, then you really can't determine the PR interval. So, for example, here you have kind of these long PR intervals. So what I like to do is kind of find a P wave that starts somewhat on a large box line and see, oh, if that's larger than one large box, then I'm looking at kind of that prolonged PR interval. So this is a first degree AV block. Over here, we're looking at, once again, that's almost 2 full large box wide. So we can look, are they all pretty much consistent? And here you're actually seeing a short one. It gets longer enough that the QRS complex drops. And so this is second degree AV block type 1. Over here, you're looking once again at these P waves, but they actually seem to be pretty consistent in their length. They're just a little bit longer than they're supposed to be. And so that's considered second degree AV block type 2. Finally, you can look here and look at how short that PR interval is. In fact, it never even goes isoelectric or flat. It just goes straight into the QRS complex. So this is one of your pre-excitation syndromes like WPW or Wolff-Parkinson-White. So here I've got labeled the PR interval is 120 seconds to 200 milliseconds. Now you're looking at the PR segment, which is different than the interval. The segment is actually this isoelectric line from the end of the P wave to the beginning of the QRS complex. We're trying to see, hey, is this normal, depressed, or is it elevated? So for example, this one's really hard to see, and honestly, PR segment depression is always really hard to see because it's hard to tell where the normal line is supposed to be. And so you can see that not only are there ST elevations here that are kind of making this look higher, but there's also this kind of downward slant, this kind of depression below the main line, which is supposed to be right here, considering it PR segment depression. This is actually pericarditis, which is why you see those ST segment elevations. We'll talk about that in a minute. But here you should see a flat PR segment. Then we move on to the QRS complex, and this is one of the most important things that you're going to look at. You should first see if every QRS is present, but you've kind of already determined that from saying, is there a P wave before every QRS? So if there's not every QRS, then it's probably some type of block. Then you ask, is there normal morphology? Is it just a single point, or are they multiple points coming up and down? If it's normal, you can usually tell because it's that single point. If it's multiple bumps, then it's usually something like a bundle branch block. As far as the width, if we're looking at more narrow widths, we're looking at more of an atrial or SA node origin, because the narrower width means that the ventricles are still depolarizing relatively normally, right? Because the QRS complex is always going to indicate how the ventricles are depolarizing. However, if you have a wider QRS complex, then you can tell that it's taking a lot longer for that ventricle to fully depolarize, and so you're seeing that on EKG. So if a beat is coming from has a narrower QRS complex but other abnormalities, it's usually coming from that atria. However, if it's wide and thick, then it can be from that ventricle or things like hyperkalemia, which really impact how the ventricle depolarizes. Finally, you can check the height, looking at normal voltage versus high voltage and low voltage. The biggest low voltage things we're going to see are different pulmonary diseases like COPD, because they actually change and shift the anatomy of the chest, which is what we're measuring in terms of the relationship to the heart. So you may have this widened chest cavity that's really gonna decrease the power that you get in that EKG. It's also gonna make it so that the lungs are maybe more of an abundant presence and the heart is situated back farther. So low voltage, think pulmonary diseases. If it's high voltage, then you're looking more at these types of hypertrophies. And because the QRS complex is looking at the ventricles, we're looking at ventricular hypertrophy in these voltages. So looking here, this is what your wide versus narrow is. So once again, think if it's wide, that means the beat is ventricular in origin or there's an issue with the ventricle. If it's narrow, then it's probably more likely atrial. For bundle branch blocks. Now, everybody always told me the analogy of scissors versus bunny ears, and it took me forever to figure out what the crap that meant. But these are your bundle branch blocks, and honestly, they're pretty obvious. You don't really miss these on EKG, as long as you know which leads are to the right and which leads are to the left. So V1, 2, 3, if you're starting to see kind of this double bump in V1, 2, and 3, then you're looking more at a right bundle branch. If you're seeing them more V4, 5, 6, it doesn't matter if they look like scissors or bunny ears or whatever. If you're seeing that double bump, then you're really looking at a left bundle branch block. So for example, here you can see leads V1, 2, and 3. You can see this double upstroke of the QRS complex, and that's going to be a right bundle branch block. Over here, I know it looks odd over here, but I want you to really pay attention to lead V6 and V5 where you can see this double bump. That's going to indicate more of a left bundle branch block. So we go over here to the QRS complex. It should be about 5 to 30 millimeters high. Let me tell you that when you know, you know. So for example, we'll look at some low voltage. You can tell without even knowing what type of measurements that you need that these are really short, if not inverted QRS complexes. These are a problem. That's very low voltage. Even in these leads that are V1 through 6, you're seeing short QRS complexes. So that's low voltage. For high voltage, you're looking at hypertrophy, and here's really the textbook criteria, but hypertrophy is obvious when you get it in clinic. So the S wave in V1 plus the R wave in V5 are going to be greater than 35 millimeters. So remember that a large box is 5 millimeters, a single box is 1 millimeters. For right, you're only looking at the R wave in V1. So once again, as long as you know which leads are right and left, then this is really obvious. I mean, look at that. It's just going off of the charts. You're not going to have a question whether or not that is ventricular hypertrophy. Now pay attention to the fact that that's the S wave in V1 and in V5, you're seeing this really tall R wave. That's left ventricular hypertrophy. Over here, you're not really seeing that huge wave in V5. You're not seeing an S wave in V1. So as you look at V1, you can tell that that's more right ventricular hypertrophy. Now for the Q wave is going to be really what helps us determine if there's any type of ischemia or infarction. So the QRS complex should have a small downward deflection, upward deflection for the R wave, and then another downward deflection for the S wave. When that Q downward deflection starts getting large, then we get concerned that there's a block or an infarction. So really it should be about 1/3 the height of the QRS. If it gets any larger than that, then we're starting to see issues. Now, if it's accompanied by ST changes or T wave changes, then you're really going to think that it's an current acute problem. But if it's isolated, these changes in Q waves with no ST changes, then you're likely looking at an old infarct. Now, as we saw in one of those old EKGs, one of the 12 leads, we saw WPW, and you saw how the shortened PR interval as well as that slurred upstroke. It looked kind of like of the QRS instead of sharp lines. That's more going to be a delta wave in WPW. So I really like this type of diagram. I have one more diagram for you to look at, but you can see a normal QRS complex. As you start to progress to more of an ischemia, that means you're kind of losing blood, you don't have a lot of oxygen there, but it's still going there. You see kind of more of these ST depressions, T wave is peaking, and here this will be down lower for those ST depressions. However, as you start going into infarctions, you're getting full ST changes, and you may even start having these pathological type Q waves where the Q wave starts to get bigger and bigger. Of course, these are a little bit small, but as they're accompanied by these T-wave inversions, then we're looking more at an acute process going on. However, in the future, we have a normal QRS, we have a normal T-wave here, a normal ST, but we have this Q wave going on. That's really going to signal fibrosis. So once again, ischemia, injury, and full infarction, we're seeing some issues in not only the Q wave, but the ST segment elevations. Then we're looking at R wave progression. This is one of our things that we look for in the QRS complex because we want to see a normal R wave progression across the leads. The biggest thing that this is going to help you determine is, are your leads placed appropriately? Otherwise, we may have some type of infarction if you double check those leads and realize, hey, one of these areas of the heart is not depolarizing correctly and following that trend. So first we're going to look at a good R wave progression. Start small, larger, larger, larger. That's one of the largest, and then in V6 it's all right if that dips down just a little bit because it's farther from the heart. So that's a good R wave progression. This one is actually lead misplacement, and you can tell that, look at how large the V1, 2, 3 are compared to V4, 5, and 6, and this is completely backwards. So that's where you really need to check your leads. Next is the J point. Now the J point's a little bit odd because it's really not going to mean a whole lot until it kind of does really a hallmark disease, which is hypothermia. So the J point is where the end of the QRS is and where it signals the beginning of that ST segment. Now you can have multiple different ways that the J point changes, but the one I want you to focus on is this J wave. If that's present, it's called an Osborne wave, and it's present in hypothermia. So you can look here. Obviously there's this abnormal little bump right here, and that's where the J point is supposed to be, indicating that there's an Osborne wave present. And you can see that it may trick you up and make you think that, hey, maybe this is a bundle branch block, but this is actually present in every single one of those leads, and so you can tell that it's more of that Osborne wave indicating hypothermia. So we've gone over a lot here, but we know that the QRS complex is present, should be 80 to 120 milliseconds, and that the J point should really be flat at the base to help us determine, hey, is there anything else going on between the QRS and ST segments? Next, for the T wave, of course we're checking that morphology and orientation, so we want to make sure that it's upright and that it's not inverted. If it's inverted, remember that the T wave is going to signal the repolarization of the ventricle. So if it's inverted, then we're having a repolarization issue. So once again, it could be infarction. It could be something like a pulmonary embolism that's taking much, much longer for the ventricles to pump that blood at a higher pressure and causing them to have an issue with repolarization. However, one of the other large things that you're going to look at is that height. And you should tell that the T wave is about 2/3 the size of the QRS complex or less. If it starts to get peaked and inverted, those are the times that we get really concerned. So over here you can tell, look at how high these T waves are. Now you may think that that's a QRS complex, but you can tell that that's a P wave a QRS complex, and then this massively peaked T wave. I'm going to be honest, it's never going to be this obvious unless you have a patient who's on the table, missed 5 dialysis appointments, their potassium's at an 8, whatever. But most of the time, this is going to be a lot more subtle. I just wanted to show you how really extreme those peaked T waves can be. So once again, this T wave should be less than 10 millimeters or less than 2/3 of the QRS complex. Now I've covered up the U wave here because you really don't need to pay attention to that. It's not going to help you a lot. It's not really high yield. Now, our big one is our ST segment elevations and depressions. Now, I do not want you to ever look at an EKG and only identify the ST segments. This should be one of the later things that you're doing. However, your eyes are automatically going to kind of turn to that. If you're in an emergency room setting, that may be the only thing that you're looking for, but do not let that stop you from seeing the other things that are underlying in that EKG. So with that being said, we're first going to look at, is that ST segment depressed? Is it decreased from that main line? And I'll show you 3 different ways that can look, either upsloping, downsloping, or horizontal. Now, these are some of the different things that can be occurring, an NSTEMI, a bundle branch block, or even a pulmonary embolism. But remember that tachycardia is still going to be the most common thing that you see with a pulmonary embolism, even though there's all this specific criteria for an EKG with a pulmonary embolism. Most of the time, you'll only see sinus tachycardia. Then we talk about elevations, and these are our STEMIs. These are our big red flags. You need to do something right now. Probably the number one indication for getting an EKG is concern for a STEMI, but the criteria is that there must be 2 contiguous leads with greater than 2 millimeters of elevation. And the location of those ST segment elevation is going to help us determine and pinpoint the location of the infarct in terms of which artery is actually blocked. Additionally, you should see reciprocal depressions. So sometimes my eyes have an issue where I go straight to the ST segment depressions and I get tripped up in those, but don't actually look for ST segment elevations. And it turns out that those are just the reciprocal changes. So if you see ST segment elevations, there should be other leads where you're seeing ST segment depressions. Now, if you're seeing ST segment elevations in every single lead across the board, then you're looking more at pericarditis and not at an infarct in every single one of the vessels. However, some of the infarcts may be in multiple locations. It's just very, very, very unlikely. And that's where you can kind of look to other clinical criteria for pericarditis to make sure that that's your top differential. Now for downsloping, this is really going to be digitalis excess. That's digoxin, and I'll show you one little clip of that. So for ST segment depression, these are the 3 morphologies that I was telling you. What's most important is determining where is that isoelectric line, and then pay attention to if there's a change in that ST segment from there. Here's my favorite picture ever to help me determine where infarcts are. It tells you which leads are which type of infarct, and then additionally what vessel is occluded. So memorize this, print it off, take it with you. It will save your life and other people's lives. Over here, we're looking at our ST segment elevations, but before that, remember that we've checked, is there a P wave before every QRS complex? Okay, yes. We've looked at the rate. We're determining 3, 150, 100, 75, so it's a little bit between 100 and 75. We're looking to see, oh, that's a normal PR interval, that's a normal P wave, that's a little bit maybe wide of a QRS. The T wave is pretty peaked off of the baseline, but there might be something else going on here, especially in V1. Oh, there's some ST segment depressions. We look at our axis, it's about normal. And then all of a sudden we start noticing, hey, as I look at these ST segments, there's some areas where there's these large ST segment elevations. So we have it at 1, we have it in AVL, we have it over here in some of the lower V leads. We can determine that that's a lateral MI, and really that's going to be occlusion of the left circumflex artery or even part of the LAD. Now over here we're looking at all of those same things again, but then we're really trying to determine where is that isoelectric line. This is a much more subtle of an EKG, but you can see in leads 2, 3, and AVF, if you look at where that PR segment is, that ST segment is really off of the baseline, and that's where our concern comes from. We consider this an inferior MI, and if somebody hasn't told you yet, never give nitrates to an inferior MI, never give morphine to an inferior MI, never give beta blockers. Pretty much the only thing that you're going to give is aspirin and get them to revascularization. Now here is one of our final things that we're looking at, which is the QT interval. Now, an easy rule of thumb is that if the QT interval is longer than the rest of the cardiac cycle, then we're in trouble. Now, the corrected formula is over here with the Bizet's formula, and you can really just get on MD Calc. That's supposed to say use MD Calc. But males and females have a slightly different time frame, but you can usually tell when a QT interval is prolonged. And the reason we care about that is that literally, this should probably say sudden death, but I don't know, instant death felt more dramatic to me. But long QT syndrome is a risk for development of polymorphic ventricular tachycardia, which can lead to instant death. So if people have these long QT syndromes, they may walk around with it for years before anything happens. And we can be sure to not give them specific medications that are going to trigger an increase in that length or arrhythmias. We can really watch out and prevent other issues. Other changes in the QT intervals are going to be things like changes in your calcium, because calcium is necessary for the repolarization of the ventricles. So looking here, I mean, it's pretty obvious from just looking at it. Look at how many large boxes, 1, 2, 3, almost 3 large boxes for that QT interval. This is our long QT syndrome. This is what we call polymorphic ventricular tachycardia. Once again, you can see that there are wide QRS complexes, which indicates a ventricular origin. These aren't consistent in their morphologies or in their intervals, and so we call this polymorphic, multiple morphic forms of ventricular, because it's wide and it's a tachycardia. This is the rhythm that people with long QT syndrome are usually at risk of. Now, here is your summary of all of your different changes that you have on there, your different measurements, what the specific points or segments should look like, and you can kind of use this to make sure that you're well aware of each part of the QRS complex, the P waves, T waves, and their relationship with one another, to make sure that you're following that entire course of the cardiac cycle, from depolarization of the atria, signaling down to the communication with the ventricles, and repolarization of the ventricles that help you determine if the heart is functioning normally. The last thing that I'll say, and we've kind of already touched on this, is that make sure that the T wave and the P wave are separate. You know, you want to look at their relationship to one another and determine, are they running together for one reason or another. Usually that little camel hump that we talked about, that buried P wave within the T wave, is going to be something like SVT. Then we can finally come back to our normal beats, our abnormal beats, I apologize. These were what we found in the beginning. I want you to star them, circle them, whatever you need to do to realize that you have to look at them towards the end. So the underlying rhythm here could be somewhat normal, but then we have some of these aberrant beats, and this is actually a multimorphic ventricular beats, and they're definitely out of place. You can tell that they're these very wide, ugly, gnarly things, but because they're this wide, we can tell that they're a ventricular origin. There may be ones that are narrow that are aberrant, and that are definitely out of place, but they're more that narrow atrial origin. The next thing you're going to want to see is maybe there's only 1 or 2 on the strip. Is that really going to impact your patient? It shouldn't. So you're going to ask kind of, is it symptomatic? You know, you may have PVCs, PACs that are just part of their normal pathology. They're just kind of these benign, asymptomatic beats. However, there can be times when these abnormal beats get pathologic, and something like this strip is a pathologic strip. So if you're seeing greater than 6 PVCs in a full 10-second course, then you're looking more at sustained or non-sustained VT. If there's 3 or more in a row, then we're really having issues with the ventricles. And then if they're greater than 30 seconds, we're looking at something like a sustained VT. So although part of the EKG may be normal, we still have pathology that we're really concerned about. So that's the end. We looked at the rhythm, we looked at the rate, axis, the waves, the intervals, the segments, and then determining if those abnormal or aberrant beats are something that we need to be concerned about. Now, I know that we went through a lot, and if you did exactly every single measurement on every EKG you ever went on and looked at the every single strip, you would be there forever. The point is, get used to kind of this pattern. You should be able to do this fairly quickly by eyeballing and saying, you know what, I can tell that that's upright, I can tell that that's normal or abnormal, and then you can combine kind of those findings to form a diagnosis at the end. I never want you to have an EKG that just pops up on screen and you automatically say, this is the rhythm that it is, or this is the diagnosis, because although it may be obvious, you only see what you're looking for. So if you only look for that initial, oh, I'm guessing what the strip is, then you're going to be in trouble, because you're going to miss maybe those ST segments that are elevated, especially if they're subtle. You may miss a block of one type or another. So we really want you looking through every single portion of that EKG to determine, hey, what is really going on with my patient? Is there an underlying disease? Is this EKG trying to throw me off? And then as you look deeper, you can find really the diagnosis for that patient. If you have any questions, please let me know. And I hope that this helps you to really have a good review of EKGs and to summarize all of the things that you've learned this semester.